Hi, this is Brian Kim. I'm going to share with you this case of a patient with a small to borderline pupil, dense cataract, and also a diffuse scar. It causes a little bit of glare, and so that you're going to see how I'm able to perform double chop, cross chop, mechanical fracturing forces, pulling pieces up out of the bag. And despite poor visualization, which I've always said in my previous videos, even with small pupils, you can still do cases with poor visibility. Same goes if you have a corneal scar. So you can see here there's quite a bit of diffuse haze. It involves centrally as well as nasally in this area here. And so you'll see that I'll be able to use my techniques to still effectively disassemble this lens. So I'm using a cotton tip to center the eye, hold it straight, and then I'm using a corneal mark to help me center and size my rhexis. I'm using the cotton tip to turn the eye to the left, and I make my paracentesis incision, making it flat to the iris plane, which will give me a nice self-sealing corneal incision due to the corneal shelf. I'm injecting some intracameral lidocaine and then some intracameral epinephrine. I'm going around circumferentially, trying to expose the entire iris to the medicine, but you can see there's very little effect. I'm injecting some dispersive viscoelastic to inflate the anterior chamber and to help viscodilate the pupil. I'm looking at this case now and thinking that I could have used trypan blue, again because of the corneal scar, but I felt at the time that I could see well enough to go ahead and do my rhexis without any dye. I'm doing my triplanar corneal incision. I make a vertical groove, go into the deep part of the groove with the blade, tunnel through the cornea, and then enter, and this is a triplanar corneal incision, which I use the cannula to help manipulate the eye for me. I'm doing my puncture style capsular rhexis. I puncture and then pull down. You can see the tear went slightly to the left side. I grasp it and then create a flap going counterclockwise. I try to stay about the size of the pupil in this case. I'm having my assistant drop BSS to help my visualization, again in that area of the corneal scar. I burp some viscoelastic out of the eye, and this is my capsular fornix hydrodissection technique. I place the cannula out to the contralateral equator underneath the anterior capsular rhexis edge, point the tip down. I get a nice fluid wave, rotate the tip back flat, decompress on the left side, sweep on the left side, and then place the cannula to the right side, pointing it downward so I can hook it. You can see the lens rotated nicely. I'm going to irrigate the surface of the eye first, making sure my tip is correctly exposed. Lift the incision with a chopper, go in an atraumatic fashion, place the chopper in. I'm going to remove the surface epinuclear material. This is somewhat of a dense lens. I'm going to place the chopper out underneath the anterior capsular rhexis edge, contra-incisionally, turn the phaco-tip vertically, sub-incisionally, crushing the lens piece completely in half. This is a double chop maneuver, bringing both chopper and phaco-tip together. That's why it's called the double chop maneuver. I place the chopper out to the contralateral equator, pulling it centrally towards the phaco-tip, crushing the right heminucleus in half, and that's the cross chop maneuver. I'm trying to use a little bit of vacuum to pull that first quadrant up. It didn't work. And so I'm using the chopper to pull that first quadrant up, and then I'm grabbing it with high vacuum and then pulling it up out of the bag, chopping it, and then trying to emulsify each piece. I go back with the chopper pulling that second part of that first quadrant up, grabbing it with high vacuum, and then emulsifying it. Again, because the pupil is smaller, I'm using the chopper to do a lot of that manipulation. I'm mobilizing that second quadrant in front of me and then grasping it with high vacuum and then using mechanical fracturing forces, crushing the lens pieces into smaller pieces and then emulsifying the lens. I'm just very carefully trying to turn the lens in front of me. I place the chopper out to the equator. But you can see I didn't turn the lens quite enough, and I got a little bit of a wedge that I resected. But I'm going to turn the lens a little bit more, place the chopper out to the equator, and then I'm able to bisect this lens completely in half. You can see the density of this lens. This is not a soft lens. This is quite a bit of a dense lens. And again, small pupil as well as a corneal scar. And I'm going after this one quadrant, going around the lens piece and just manipulating the lens pieces so that the chopper and the fingertip are really bisecting that one quadrant, and you can see the chop was effective. So I have three pieces now. I'm going after that middle piece. I'm going to place the chopper around the lens piece, making sure it's only around the lens piece. Again, crushing the lens piece between the chopper and the fingertip. You can see there is quite a bit of density to this lens. It's got a chalky, dense consistency, and I can feel the density as I'm bringing both instruments together, crushing the lens piece. You can see I'm having to use quite a bit of ultrasonic energy. And again, because this is a dense lens and a small pupil, I have to use a little bit more ultrasonic energy to remove the lens pieces. Trying to protect the corneal endothelium, so I take the chopper out and fill the eye with some more dispersive viscoelastic to coat the corneal endothelium. I'm going to manipulate that third quadrant, place the chopper out to the equator around the lens piece, crushing that third quadrant completely in half. Hooking the lens piece, pulling it up a little bit, and then crushing the lens piece and emulsifying the lens pieces. Using a little bit of vacuum to pull that one piece up, crushing it between the chopper and the fingertip, and then emulsifying the lens pieces. And here there's some jagged pieces, but nothing easily accessible to me within the central safe zone. What's tempting here is to try to grab the lens piece with high vacuum, which a lot of people would do. That is a poor move in my opinion. I'm trying to hook the lens piece, but it won't come. I'm trying to grab the lens piece, staying at the iris plane with high vacuum, but it doesn't come. So rather than trying to place the fingertip deeper, which is really not the move, I'm trying to patiently manipulate the lens piece with the chopper so I can get it up towards that fingertip a little bit easier. So you can see I'm turning the lens piece, and then I got around the edge of that piece, and then I was able to crush the lens piece against the fingertip with the chopper. I'm using high vacuum now to mobilize that last part of the fourth quadrant, and then using mechanical fracturing forces to crush the lens pieces between the chopper and the fingertip, and then emulsifying the lens pieces. So again, you don't ever want to go after a lens piece deep in the bag with the fingertip, especially when it's a small pupil and especially when your visibility is poor. And that's why I'm so confident, because I'm using the chopper. I can survey the bag, pull pieces up very, very safely, very, very confidently, without risk or fear of rupturing the posterior capsule. There's some small jagged fragments still in the bag here. I'm just pulling those lens pieces up with the chopper and then emulsifying the lens pieces. This is actually some dense epinuclear material, and that's one thing I noticed here too. This epinucleus is not very soft. It doesn't come to the tip. It doesn't collapse into the phaco tip very easily. It's actually fairly dense, and you can see that here. Dense epinuclear material. Again, I'm having to crush and chop even this epinuclear material because of the density. So there's some tiny little fragments around. Again, with dense lenses and small pupils, you always worry about having retained lens fragments with these cases because it's a dense lens and a small pupil, and pieces can fly up underneath the iris here. As I take the chopper out, I can see there's a pretty big nugget right at the incision, and I'm trying to tease it out. And then I switch, take the chopper out, pushing BSS in, take the phaco tip out, and then switching to the INA. I'm just going around in my subincisional area, making sure I don't have any frags, because the frags tend to go towards the incisions, and so I want to make sure I don't have a big fragment that might end up staying in the eye after I'm done with the case. So I'm starting subincisionally, removing the subincisional cortical material with this nice polymer tip. And I'm going around circumferentially very carefully, grabbing underneath the anterior capsule edge, but not with super high vacuum because I don't want to grab the anterior capsule. So this is with foot modulation, making sure I'm controlling so I don't use excessive vacuum in this situation, but of course I have to get under there to get the cortex. And once I feel the bag is pretty clean, I'm going to go to the polish mode, and I'm polishing underneath the anterior capsule rhexis edge. If I do snag some cortex like I do here, I can switch to the cortex mode and then switch back to the polish mode. Going back again, sweeping and sweeping, and if I catch cortex, I can do that same maneuver again, but otherwise I'm polishing underneath the anterior capsule rhexis edge, and now I'm polishing the posterior capsule surface. Using that polymer tip, I can make sure any of the small, fine, wispy lens material is removed. So I think about pulsing the subincisional space with the cannula, but again, because of poor visibility, I decide not to, and I go ahead and fill the capsular bag with a cohesive viscoelastic. And I turn the eye so I can make sure I can see the edge of my anterior capsule on the nasal side so that leading edge of the haptic and optic can go in. I use a Maltzman to make sure that the capsule is intact and that I can place that optic underneath the anterior capsular rhexis edge. I then use a Maltzman to disengage each haptic off the optic, and again I'm verifying with the Maltzman that the entire lens is again within the capsular bag. I think I did this extra step mainly because that corneal scar is a little bit obstructive to my view. So I go in with the INA handpiece, and I go back with the Maltzman, just making sure that the lens is completely in the bag. And now I'm going to go under the optic as I usually do, making sure the viscoelastic is removed from the capsular bag, tilting the lens, and then putting the lens back into the bag. Again, I'm using the Maltzman to make sure that the lens is completely in the bag. Just tapping the lens, making sure there's no more viscoelastic, and then I'm going to switch to the visco mode, removing the viscoelastic. Here you can see I'm using my finger, just explaining to my staff why this was a challenging case because of that very subtle but diffuse corneal haze. So I push BSS and hydrate my incision. So again, this brings everything together here because this is a small pupil, this is a dense lens, and not only that, there's a diffuse corneal scar that's causing glare. And so I'm able, as I've preached before, if you have good technique, you can pull pieces up out of the bag, even with poor visualization. And you can see, even in this case where there's pretty diffuse corneal scarring, I'm able to confidently disassemble the lens, pull the lens pieces up out of the bag, keep the phaco tip in the central safe zone as I emulsify, which is the safe way to do it, using the phaco tip as a chopper as well to help disassemble the lens, of course not activating vacuum or ultrasonic energy when I'm using the phaco tip as a chopper, placing the phaco tip deep in the bag or manipulating the phaco tip, whatever I need to do so I can crush the lens pieces, being able to confidently pull pieces up out of the bag with the chopper and emulsifying this lens. Again, I feel like this is the safest and most efficient way to perform lens disassembly. So I hope this was helpful to you, and I thank you for your attention.